Very good evening, my beloved colleagues. For today, just to cross-check my voice, Dr. Nawaz, can you hear my voice well?
Assalamu alaikum. Yes, sir. It's very much
Assalam.
clear.
Thank you. And the screen is okay?
Yes, the screen is also okay.
Thank you. Thanks a lot again. So for today, we're going to start now. First of all, hope that all of you are in good health, especially in this holy month of Ramadan, and passing your time with good days as well. And hopefully those who are AKT aspirant as well as maybe some colleagues of OSCE aspirant as well today. So we believe that today's topic discussion will be much helpful for both of the groups as well as any learner with us today, not the examining. The topic is a little different topics, not too much difficult, but I like to comment that is a relatively neglected topic, but practically very important topic. And if you can improve or develop your skill how to do the fundoscopy, it will be very useful in your practice. Don't think that the fundoscopy is a matter of only the ophthalmologist or the specialist doctor. For this reason, the exam questions contain topics of fundoscopy, not only AKT. In the AKT, they will give you some pictures with some clinical scenarios. But in the OSCE, that means in the practical part, not only even to say the OSCE, rather any clinical exam in the world, they will give you a clinical background, clinical information, and then to do the fundoscopy procedure. But to be clear, in the OSCE exam, in the South Asian pattern, you don't need to go for the fundoscopy clearly. Till now, these instructions are not given. But in future, it may be given that do the fundoscopy. I am just forecasting. For this reason, everybody should do your practice in your own areas with the help of colleagues. And today, our discussion, we believe that will be much helpful for you for your understanding. So if we start now with my humble introduction, and from our institute again welcoming you to today's very important session with the moral alert as well always. So this is the topic repeating for you now. And first of all, I like to invite you to see a procedure, how it's to be done. And if you are for the AKT examining, please don't mind that we are showing this thing because today's topic is a little different practical topic. So it will take few minutes only. You just look at and try to listen the instructions be given by the examiner here. And after that, if you want, you can discuss, but we will not be discussing too much this thing. Just opening the video for a few minutes. You just keep your ears alert and your eyes targeted to the video, please. How to do it?
Hello there, Sarah. My name's Anthony Kawadra. I'm one of the doctors. Is it okay if I examine your eyes? Of course. Okay, thank you very much. I'm going to be using a bright light. Don't worry, it won't be doing you any harm, and I'll be coming in quite close. I just want you to look at the distance target there. And if you could just stay looking that, even if I get in the way, just imagine you can see through me. Can we please have the lights dimmed?
Just to interact here, Dr. Azra, did you understand what actually the instructor said to the patient?
Yes, sir.
Very nice. Just a little far away, around 30 centimeter, just focusing and coming closer to the eyes. And now from at the I am just important message to share a little behind.
Just
there,
imagine you can see through
from
me.
there.
Can we please have the lights dimmed?
I'm just repeating, you see, from there, From there, I'm just pausing here. When the retina is visible or not, actually retina is not visible. Rather, you will find a rounded area and with a background of redness. It is called the red reflex. I will show you in subsequent some pictures what is the red reflex, and it is normal. You cannot see the retina from this distance. When you come closer, then you will see the retina. Please proceed now and follow. You will see just different quadrants of the retina, and the area visible by this light source is called the fundus. Fundus doesn't mean whole retina.
Okay, Sarah, could I ask you to just look into my light for me, please? Thank you very much.
Looking to the eyes means actually examiner examining the
Can I ask you to look
macula.
up to the ceiling, please? Thank you. And down to the ground, please.
So telling to look up
And can you
and
look
down,
across to the
meaning
left, please?
to look
Thank
at
you.
different quadrants of the retina.
That's great. And just all the way over to your right. Thank you.
Checking the other quadrants.
Okay, thank you. We'll just examine the other eye now. So again, if I could have you looking into the distance.
I
and
hope this is
just
enough for you
ignore me.
now. It is enough for you now. So already you have seen just for introduction. And after looking, if you have any query, better we will discuss after the topics will go on. But very interesting thing you will see here is a video record inside the retina. You can see that this is the optic disc and some vessels. But very interesting thing we'll find here in a normal retina. Please look at the center here. Center here. What have you seen? Can anybody say, please? In the center, can anybody say?
Sir, the margins of it's hazy, not visible, is surrounding.
No, whatever. Just you can look at the vessel. There's some blood column is moving up and down.
Yes, yes, yes.
Please have a look again. Here.
Oh, yes.
Possibly all of you have seen it, as I mentioned there. It's called spontaneous retinal venous pulsations. Spontaneous retinal venous pulsations. If anybody can see it with his skilled hand, it will be very nice to see. And this is normal. This is normal. Absence of the rhythmic movement is abnormal. Okay? So it is absent in the raised intracranial pressure. Anyway, we will not be discussing here much here. Just we now like to proceed. And this is the retina and it's normal. Please try to remember the normal picture of the retina. What you are seeing now here, Dr. Nawaz, in the retina. Please tell me simply whatever you can remember.
Now, sir, the
Optic
blood
disc,
yes.
then the
Okay.
retinal vessels.
Vessels, yes.
Anything?
Macula.
Macula, yes, this is
Yes, sir,
macula.
macula.
Any comment? Any further comment? Doctor, take care of the noise. In the optic disc, any additional comment, doctor? Anyone?
Sir, it's in optic disc, the visible margins, no haziness.
Okay.
It's normal.
Seems to be normal. What is this in the center? A relatively whiter area.
It seems like protrusion.
Protein.
Something.
Protein. No, doctor.
Sir, this is optic nerve, sir.
No, no, this is the optic nerve head. This is the optic disc. This is the optic nerve head. And from there, in the back side, the optic nerve is formed and going back. But this is called optic nerve head, the optic disc rather to say. But in the center, this is area wide. It is called optic cup. Optic cup. I will show you now one by one. Just have a look, the normal appearance. These are the retinal vessels. Now I am asking, this retina of which eye, left eye or right eye? If you look at the patient's eye, just imagine in this way, what the eye will be, left eye or right eye? Please, doctor, respond quickly so that we can proceed. Anyone?
No idea, sir.
No idea. Who has the ideas? If anyone in the OSCE examinee, please.
This is
You must
right,
know.
right eye.
Right
This
eye.
is right eye. Very good. Because you are looking the eye in from the oblique focusing from here. I am moving the cursor from here. So you are looking to the optic disc, and this is the central part of the fundus when you look at. And this is the macular area. So optic disc lies medially and the macula lies laterally. What is the background of the retina? Is black, white, yellow? What do you think? Background overall? Black, yellow, white, red, reddish. What do you like to say?
Reddish yellow.
Reddish or yellow, whatever say. And the name of the vessel?
Retinal vein.
Retinal, but there's a name of this branch.
Central retinal artery and vein.
No,
Both.
doctor, central retinal artery within the optic nerve there, not here.
Vein. It's central
But this is the
retinal vein.
branch. These the branches are there. Artery, which a bigger one is vein or artery?
A bigger one is vein.
Yes. The narrower one is the artery. So it's a temporal arcade, superior temporal arcade, and below is the inferior temporal arcade. Okay, let's go further. Is it normal retina? Is normal retina?
No, sir.
No. What abnormality we're looking?
Its
Left.
color is dull.
Color is blackish or black.
Blackish. Yes.
So for this, it is not normal.
And optic disc is looking widened.
No, doctor.
Optic
It is
also
a,
not looking.
optic cup is visible here. This is just labeled only. In the previous picture, not label. But now it's picture, the optic disc, optic cup. Overall
It's a normal.
background is black. Overall background is black. This is anybody from our colleague from Sudan today? Maybe who is talking? You are from India or Pakistan, maybe. Okay. Dr. Shazia or anyone. So the previous one
Yes.
is a non-black people, and this is the black people retina. Usually. So it is also normal. So don't be confused. Okay.
Okay, this is normal.
Don't be confused. So let's see now. It is of which eye now, please?
Left.
Left
Left
eye.
eye.
Yes, very right. Left eye. It's a simple quiz. So this is the normal fundus. So you now see the background pigmented retina. So what we like to see in the retina, all the information is given here. I am requesting all of you, please make a snapshot minimum of this picture. This is very basic. This is very basic. We will try to describe, and you try to remember throughout the process of discussion today. Margin should be sharp. This is the disc. Margin sharp. Color yellowish orange to creamy pink. Whatever you can define. This is the disc color. We are discussing the disc. Shape will be round or oval. Cup to disc ratio less than half. So this is the central whiter area is cup. It should be less than 50%. Should be less than 50% normally. If it crosses, then there is a problem. We will tell what will be the problem.
Intraocular pressure will be increased.
Yes, definitely. Definitely. We will discuss later on. In the vessels now, the artery and vein ratios 2:3. This is just number of the artery, 2:3. Artery venous crossing. Artery, you see, usually crossing the veins, but there will be no depression in the veins. It is called the nipping. There should not be any nipping, and no arterial light reflex. That means you focus the light and there will be no reflection towards your eyes. That means the arterial line will be red, wholly red, or even the vessels, the vein also same. Fundus background, that means the whole area is the fundus. I told you that fundus doesn't mean retina, only the area visible. This area is called fundus. So we are telling it fundoscopy. In the fundus shouldn't be any exudate or hemorrhage, and the color will be red to purplish in general, but from the African origin they might have pigmented retina. It is also normal. It is additional message, try to remember. And the macula, you see, look at the macula central part, located 2.5 disc distance temporal from the disc. So this is the disc, this is the macula. This distance is around 2.5 disc, like this size of disc, and no vessels around macula. In the macula there will be no vessels, and macula may be pigmented in addition also. Especially, again, like to say that in the African origin people, as well as in any people also, there you can see that a little different color, concentrated color of blackish also you can say here. So you have any query now, doctor, please? This is very important to see. Anyone? No. So now when you start the viewing the retina from a little distance, you are looking, you see, in the pupillary area, the round area, it is called the red reflex, not the light reflex, remember. It is called pupillary red reflex when you do fundoscopy. This is normal. But if it is like this, if there is a haziness, opacity, it will be abnormal. And it is found in the patients of cataract. Very simple, patient of cataract. Now again, it's a bigger semi-diagrammatic picture. So this is the normal red reflex. Okay, what is this in the central white, doctor? What you are thinking? The central white?
Optic disc.
No, doctor. It is just the light reflected, light of the fundoscope. Nothing else. Okay? You cannot see the disc from the distance. It is a distance, 30 centimeter around. Focus the light and going closer, then the retina will be visible. So this is actually in the, you are looking rather to say in the lens area. And this is the reflection of the light. It is not the optic disc. And now you see the red area is opaque, spidery black appearance. This is the features of cataract, remember. And again, what is this?
Light reflex.
Yes, it is. It's a technical thing, artifact rather to say. It is actually not the picture of the retina. The focused light reflecting back to you. Hopefully it is easy to understand, right, doctor? Spidery black cataract. Now what you are looking here, please. As much you interact, you will learn more today, like every day.
Cupping of eye optic disc increased.
Yes, cupping naturally there, but it is increased. And what you are looking at the vessels, are they coming from the center? No. Seems that vessels are coming from the periphery. Okay? Just coming out. So what is the underlying diagnosis?
Intraocular pressure increased.
And any disease?
Papilloedema.
No. Papilloedema means there will be redness. There will not be cupping like this. And remaining retina, I'm sorry, the picture is not much clear though, but apparently the remaining, other than the disc, is there an abnormality in the retina? No.
Neovascularization, hemorrhages.
Nothing there. So this is in enlarged optic cup. Enlarged optic cup. Is it more than 50%?
Yes.
Yes. So the diagnosis will be Glaucoma. Glaucoma. And you now look at the optic curve measurement stepwise, go down. Okay, now clear how glaucoma looks like. The cupping is enlarged or increased. This is the glaucoma. So glaucoma means raised intracranial pressure, raised intraocular pressure, right? Intraocular pressure. But papilledema is the features of raised
Intracranial.
intracranial pressure. So don't be confused with the both words. So now you compare healthy optic nerve. This is enlarged optic cup. So this is glaucoma. Fine. Now come to the term optic atrophy. Optic atrophy. So there will be three types of optic atrophy. You can go through the book detailed, doctor, just to let you know the words. And to have an understanding, the primary optic nerve atrophy means the damage happened to the optic nerve. Direct optic nerve problem. Directly. The disease process involving the optic nerve directly. It is a primary optic problem, primary optic atrophy. And if there is a papilledema or papillitis, subsequently optic disc is in trouble. It will be told as secondary optic atrophy. Consecutive optic atrophy means if there is a retinal disease, for example, you said that there is a hemorrhage, there is exudates or other damages. Subsequently, it involves the optic disc. So retinal disease included the optic disc problem. It is called consecutive optic atrophy. Just as a terminology, doctor, just to remember. So we will try to show you the pictures of three types. First one, this is primary optic atrophy. Now, doctor, you can confuse with the glaucoma here because the area is white. What is the difference you are looking?
Central origin of the arteries.
Yes, the
From the
arteries are
center.
coming from the center. But in the glaucoma, you will see the vessels are coming from the periphery. Otherwise, you might be confused. So this is optic atrophy, clean cut margin. Okay, white area in the optic disc. And there is no other problem in the retina. Okay, there is no other problem in the retina. So it's a primary optic nerve disease, primary optic atrophy. Second one, if the margin is blurred, you may argue or make a debate also, but try to imagine if the margin is blurred, then we will say it is a features as a consequence of the papilledema. So again, you see vessels are visible in the center. So this is secondary optic atrophy. And the third one, obviously you will agree that there is a retinal problem, right? Many damages are there in the retina. So in the retina, subsequently optic disc is involved. It may be looking sharp or different color, might be there, but it is not normal optic disc. Then it will be termed as consecutive optic atrophy. That's all, doctor. And these some differentiating points are there. You may not understand everything. Waxy pallor, doctor. Waxy, how can you identify? Sometimes it is very difficult to say this is white or not. So, but you are now going more in depth. Waxy pallor. Sometime you can correlate with this if you become too much expert. No problem. So these are some differentiating points. So try to remember this: primary, secondary, and the consecutive. Consecutive means retinal involvement associated problem. After the optic atrophy, now like to show you papilledema. So blurred margin. This is papilledema. Okay. That means it is the features of raised intracranial pressure. Now, if you say in the retina, nothing wrong could happen, nothing wrong without any problem. So it is only papilledema. What could be a possible diagnosis? Please, anyone? Could be?
brain tumor or something inside the cranial cavity.
Could be right. Brain
Hyper,
tumor. Other than patient does not have any cerebral problem. That means no weakness in the limbs, other thing. Only headache is very common, and your exam topic also it will be common. It will be idiopathic intracranial hypertension
Mm.
or benign intracranial hypertension. Very popular or important topic for the exam, for the AKT as well as the OSCE. And again, you see this video already you have seen. For you, should I start, doctor, to see again? Few seconds.
Yes.
So look at the center here. It's normal. It's normal. But in the raised intracranial pressure, this movement of the
not
blood
visible.
will not be visible. Okay. And there are many reasons of raised intracranial pressure. There may be arterial cause, there may be venous cause, there may be, you see that the tumor as well, and there is a secretion more or absorption less, just in this way. Even the venous thrombosis also can raise intracranial pressure, venous sinus thrombosis. So these are many things are there just to show you causes of this. Now come to the, just already we discussed the differentiating point for recapitulation. So you see the margins are blurred in the both pictures, but what is the difference there? You see that it is not white, but in the right side it become white. What does it mean? It is a consequence of
Central retinal artery here
no, doctor.
obstructed in
Central
optic atrophy.
retinal artery, don't be confused. This area actually is the accumulation of the optic nerve, not the vessels. Okay.
Yeah, but
If
when
the
supply to the
artery,
nerve,
no, doctor, if
supply to
artery
the
is
nerve
blocked,
is disturbed.
yes, if supply is blocked, the whole retina will be whiter. Whole retina will be pale. Not there.
Okay.
But the paleness is actually damage to the optic nerve. Damage to the optic nerve. So if papil edema later on become like this, what will be the term of this optic atrophy? Primary, secondary, or consecutive?
Secondary.
Secondary optic atrophy. For this reason it is white. So initially it was like that, and then later on, if it is not treated, not controlled, then patient will have such, so it will be an advanced damage, secondary. Now a very common disease, hypertensive retinopathy. Just to remember, there are grade 4 grades are there. Grade 1, grade 2, grade 3, grade 4. So grade 4 means the additional feature including 1, 2, 3 all together like this. Not that there is a different appearance. Grade 1 plus this feature is grade 2 like this. AV nipping. There will be no arteriovenous nipping. But in the grade 1, silver wearing. Another word is copper wearing. And here nipping already we discussed. Grade 3, cotton wool spots and flame shaped hemorrhage. And the grade 4, papilledema. These are additional features, papilledema. The hypertensive retinopathy. Look at different grade. Can you see the silver wearing in this picture?
Yes.
Yes, sir. This one, silver color, right? The white reflection of the light. Can you see any copper wearing? Possibly you don't know also, sorry to say. If you don't know, you cannot identify. Actually, copper wearing not much visible here. I will show you in the subsequent slide. Always there may not be silver wearing, copper wearing both together. It is true, but there may be both or maybe single. And there might be some hemorrhage and others also. But as it is mentioned, though pictures are not much very clear to say, I'm sorry. The grade 1 is tortuosity of the retinal arteries and the silver wearing. This is the one feature here. And in the grade 2, in the right side, another picture. What is the grade 2? This is nipping. This is the nipping. because arterioles are becoming hardened, and when it crosses the vein, it just gives a pressure. So it is called arteriovenous nipping. So artery cross over onto the vein. Number 3
So
grade.
nipping means crossing.
This is a crossing here. Arrow. You see, different arrows are given.
Yes. So
So this
means
is the
crossing the arteries and the
crossing.
veins.
Yes, cross.
Oh,
They usually cross, but not giving the pressure. Just to remember. For understanding, I am telling. Pressure means because arterioles become hardened. So veins are the softer. When it crosses there, you will find in the fundoscopy is a depression, rather to say here. This is the nipping. And in the third one, flame shaped hemorrhage and cotton wool spots. These are the cotton wool spots with an irregular border. Cotton wool spot, remember. There will be some little hard exudate also, but significantly there will be cotton wool. Cotton wool means retinal infarction, damaged retina. Okay. And these are the multiple areas of the hemorrhages, like it is called the flame, okay, flame of the fire. And the last one is the last stage or last grade is a papilla edema. So you see blood, optic disc, blood margins. So in when a hypertensive patient have the papilla edema, it means that patient will have all the grade 1, grade 2, grade 3 features together. So there might be some hard exudate already, cotton wool spots, multiple cotton wool spots, papilledema, flame hemorrhage all together. This is hypertensive retina for the examples of the 4 grades. Any query now? No, possibly. And as a bigger picture to show you, this is that the silver wearing, and the lower one is copper wearing. You see copper wearing. In middle there is a white line. It is called copper wearing. The whole whiteness is silver wearing. So blood column is visible here, but in the silver wearing, blood column is not visible. This is the difference. Okay. Again, some example. Okay, you understand? Papilledema with the hemorrhage. There are some white, the exudate also there, hard exudates. Okay. In the down, you see many flame shaped hemorrhage with the papilledema. So wherever the papilledema, it will be termed as the grade 4. Other features all may not be visible or you cannot identify. But hypertensive retina with the papilledema is grade 4. Again in a bigger picture, hard exudate, cotton wool, papilledema, flame hemorrhage. So after that, another disease involving the retina is the diabetic retinopathy. Please have a look. Somebody who can read for me one by one. Dr. Mohsen,
yeah. Eye with advanced diabetic eye disease.
use the headline. Now
Yes.
say one by one. IRMA. What is the meaning of IRMA? Intraretinal microvascular abnormality.
Yes.
Okay, then.
Intraretinal microvascular abnormalities, exudates,
Okay.
and hemorrhages, and then pigment from previous laser. Okay. Photocoagulation. And then,
Photocoagulation, the black areas. You know about the retina treated with the photocoagulation, laser therapy.
and then
Okay.
laser burn.
Laser burn, the same thing.
Hmm.
Pigment from the
My,
previous laser. It's a pigmented, but they are also again little pigmentation. This is a burn. Laser burn, simply laser therapy. Laser
hmm.
therapy usually found in the radial manner, radial, spreading from there, like this. It is given. But the main features of diabetes, I will show you for the detail also. They have given some a few pictures, not everything mentioned in. They didn't label everything. So let's go further. The IRMA, you can read about IRMA later on detail. It is microvascular abnormalities. But the very important thing to remember as a beginner is the blot hemorrhage and dot hemorrhage. Dot and blot. So bigger one, blot. If it's smaller, these are the dot. These are the hemorrhage. So you have to be very confident to say this is dot and blot hemorrhage. And there will be some microaneurysm also. So microaneurysm means it is not the hemorrhage.
Dilatation of
That means,
vessel at
yes,
some
it is
time.
true. It is true. But how to identify? If you say that near the vessel, there are some dot-like areas connected with the vessel, it will be microaneurysm. But if it is separated from the vessel, it will be hemorrhage, especially the dot hemorrhage. Blot you can identify easily, is a bigger area. So this is very characteristic background features of the diabetic retina. Again, don't worry, we'll show more. So number one, background retinopathy. You see, hemorrhages are there. Okay. And if it is associated with the capillaries also, you can tell, or the arteriole is smaller, that it will be microaneurysm. Microaneurysm. And here you see more dot and blot hemorrhages, including the cotton wool spot. So we discussed the cotton wool spot in the hypertensive patient, but it may be present in diabetic patient also. Diabetic patient. And remember, in real life, a patient have diabetes, this patient have hypertension altogether. This is a very common scenario. So what does it mean? You will get the pictures of both diabetic retina as well as hypertensive retina. Anyway, we are learning now in this picture, especially is in isolation of the diabetic retina. So now in the third, the proliferative retina. Proliferative means proliferation of the vessels, neovascularization. You see very tortuous vessels, very significant number here. And usually around the disc, you can see initially in the neovascularization. So proliferation means proliferation of the vessels. So it is very risky situation. Before it is said as the before means before this proliferation, if the picture is like this in the above, it is called pre-proliferative retinopathy. Try to remember, it is not like the gradation like hypertension, that the stage 1, then stage 2 or stage 3. In the diabetic patient, a patient may have this proliferative retinopathy without these features, without the pre-proliferative appearance. So it is not the sequence. It is not the sequence. And another important observation, see in the figure 1, in the macula, what you are looking?
Yellow deposition.
Is the deposition around the macula. So this is the maculopathy.
Yeah, drusen sign.
Could be drusen, but there may be hard exudate also. Okay. So if it is so in the diabetic patient, we will say it is a maculopathy. Again, maculopathy can happen in any stage of the diabetic retinopathy. So maculopathy always in emergency. Emergency means the patient may lose vision. So our job is to refer to the ophthalmologist. So these are the disease process. And now the last one, the huge damage to the retina happened by the laser therapy. Okay. Laser therapy actually it is given to save the retina from the further damage, not to correct the retinal damage already happened. Okay. So how the mechanism is, whenever there is ischemia, suppose the cotton wool is the features of the ischemia. Ischemia stimulate for the neovascularization. Okay, wherever the neovascularization, there is a hemorrhage also. The new vessels are very delicate. So to prevent this, laser therapy done. And laser therapy actually radially done like this, from center to periphery, center to periphery.
It means when there is pre-proliferative stage, then laser therapy will work
in the
better.
proliferative stage here. Before being ruptured, you're just damaging the new vessels.
Okay.
Okay.
Yes.
Idea is as such. So up to this, hopefully clear, doctor. I am just trying to give you a very simple explanation, not to be in much depth, so that you can understand. And today we said that today specially designed for the beginners, not for advanced candidate. How to classify the diabetic retinopathy? Non-proliferative, pre-proliferative, proliferative. These are the three headlines. Maculopathy is separate entity. It can happen in any type of the diabetic retinopathy. Okay. Right. Maculopathy is leading cause of the blindness here. Fine. Now, thing will be there to know about the differentiating points from the diabetic retina and the hypertensive retina. So hopefully you would get, you make a snapshot better. So already we discussed, and you can go through by yourself, doctor, the differentiating point by yourself. So actually, absolute, the very distinguishing feature may not be there. The diabetic retina may have some features of hypertensive retina. Hypertensive retina may have some features of diabetic retina. But dot and blot hemorrhage usually features of the diabetic retina. Flame hemorrhage, flame shaped hemorrhage features of hypertensive retina, like this. Cotton wool usually more found in hypertensive retina, but may be present, though it is a rare in diabetic retina, like this. Now a quiz question to you. What you are looking there, doctor? Please respond.
It's a normal.
Normal.
No, sorry,
If
drusen
there are
sign, maculopathy.
maculopathy, no.
Maculopathy, but not retinopathy. Okay, if you say that macula is a part of retina, so it is a retinopathy. But other than macula, if any damage to the vessels, already we described the appearance of normal retina. So any changes in the vessels here?
No changes.
No,
No changes. Changes in the optic disc?
No.
No
no, sir.
changes. So usually it is found like this multiple plaque-like areas, whitish or yellowish, around the macula. These are called drusen. So drusen can happen without diabetic patient, without hypertensive patient, but it is found again in combination. These are the risk factors, and usually happen in elderly patient. So this is macular degeneration. Your learning topic will be dry macular degeneration, wet macular degeneration. We will not explain here for you because we are talking for the beginners today. So this is age related. It is simply to say age related macular degeneration because it is the features of elderly. It is very geriatric topic. Okay. Do you like to recapitulate or to storm your brain now up until now? These are very common. And if any doctor here can respond now, who are here with us that you have done fundoscopy in your practice life? Who can respond? No one at all? You have done fundoscopy or you do fundoscopy regularly in your chamber? Anyone? Dr. Mohsin?
No, doctor, I
No?
haven't done myself.
Other colleague, I am not calling one by one. Please be frank and free also.
Sir, try to do fundoscopy even though the went through it, but couldn't understand a lot of things. So
Hopefully today's discussion will give
yes,
you
yes,
some
yes. Very much
relaxation and
things clear.
comfort because it should be learned very in a very simple way. Okay, if you go through the book, you may not understand if you cannot discuss with each other. You have to look at and share with other colleagues also. And technique also important. Okay, so now hopefully we will proceed to some patient now, maybe your exam questions. What is the diagnosis? It is a question in AKT exam. For example, who can say answer?
Sir, it's most likely retinitis pigmentosa. Sides are
We didn't tell retinitis pigmentosa today anyway, but could it be this black area? Could it be laser therapy? I'm just arguing.
maybe, but in laser therapy are a specific shape like dots.
In
It's not like dots. It's a something a network.
Dots. Okay, but laser therapy, I actually uttered word more than 1 or 2 times. It will be radially arranged from center to periphery, center to periphery,
Yeah.
like this in a row, in a line,
Mm.
spot to
Mm.
spot. But you are looking the blackness
Periphery.
in the periphery, not in the center, not involving what?
Vessels are.
Macula.
Yeah.
And what appearance in the vessels, Dr. Masin? Vessels are more or less.
Less.
very less from the
Very
center.
So
less.
attenuated vessels. About the disc, how does it look like?
Sir, it's clear margins, clear.
Margin clear, okay, but
It's
appearance of
normal.
color, normal. Yes, that is the thing. I will tell you, I told you that somebody will tell normal, somebody not. Anyway, so this is the description of the patient. It may be case in the OSCE or any other clinical exam in the world, even in the PACES exam also, in the postgrad fundoscopy station, if you found like this. It's very nice picture, not much common. And I can remember I got one case in my KSA practice time. This is very typical of this. And I was doing this fundoscopy before my passing exam also. Anyway, Dr. Marcin, can you read for us?
Yes, sir. 44-year-old woman complains of gradual loss of night vision. She has had increasing difficulty driving in the dark and recently stumbled on steps when leaving a restaurant. Clinical examination revealed loss of peripheral visual field. Her fundoscopy is shown below.
What is the diagnosis? So why we like to say today is that the right. I appreciate that your diagnosis is very right, and diagnosis retinitis pigmentosa. There are some associated other diseases also, especially the biochemical abnormalities. Today we will not be discussing this. So in the peripheral, it is called bone spicule appearance. Bone spicule appearance in the periphery. This is the pigmented area. Now try to learn that what is the presentation of the patient. Gradual loss, not sudden. And difficulty in driving in the dark, because as the periphery of the retina is damaged, so you understand that the rods are damaged, right? Rods and cones, in the retina. So peripheral vision is in problem. In the darkness, it is problem. What happened to the central vision?
Center is normal.
Yes, because macula is intact. Macula is intact. For this, and they're dashing here and there, okay? Moving in the road, dashing you and me, because they cannot see in the peripheral part of the visual field. Okay. And they may do the accident, right? During driving. So it is important as a legal part of your practice. So
Excuse me,
this
sir. In
is,
glaucoma, there is also a loss of peripheral vision.
yes, could be.
And
But the glaucoma fundoscopy is not like this.
yes, no clinical presentation. Both have same clinical presentation that peripheral vision is
Yes,
lost.
by the pressure effect, retina will be damaged in the glaucoma. But there is not the pressure effect. It is just damage in the cells. Okay. But another word we can say the tunnel vision. Tunnel vision. That
Yeah,
means the
tunnel vision.
the
Yes.
intact central vision is the tunnel vision. So the glaucoma can happen, but in there also the same thing can happen. But fundoscopy is not the same. Another thing I like to say you, as you stopped me, it is nice. Otherwise, I actually might forget. This is called waxy retina, waxy disc, waxy. So as I said, it is waxy, and you will telling waxy, but you will say it is normal, near normal. It is called the waxy retina, waxy.
Sir, what is the reason of this less of the arteries here?
Oh, this is a
There
retinal
are
damage, doctor, already happened. There is some biochemical problem associated. For this reason, there are the changes in the vascularity and others.
okay.
If you want to know, you have to go through the pathogenesis and others of the retinitis
So, sir, if
pigmentosa.
there is a damage to the vessel, there will be new vessel formation. Should be it could be.
No, usually it not happen. Okay, and
Mm.
it may happen in very advanced stage. Practically, we may not find it. Okay, practically we may not find it. Right. Now, next patient. Let's see, Dr. Nawaz, can you read?
Yes, sir. An 80 years old Caucasian lady present with a 1 week history of left vision become wavy and blurry. She mentioned that with her left eye, she noted her Venetian blind looking wavy and distorted. She is otherwise fit and healthy. Which one of the following would be the best next step in managing the lady's condition?
What condition now we are thinking? Any other colleague, Dr. Dashini? Hopefully you are connected well, and
80 years
are you
old.
there, Dr. Dashini? Any other colleague can comment. What we're thinking now, 80 years old, otherwise
Yes.
fit and healthy means patient is not diabetic, not hypertensive.
Yeah.
Only problem in the eyes, in the left eyes.
And the vision becoming wavy.
Wavy. What about the Venetian blinds, doctor? What do you think? What is this? Venetian blinds in the window, in the house. This is
A
the
curtain
Venetian
type.
blind.
Yes,
Yes, this is the
yes.
Venetian blinds. The horizontal lines are there. Patient telling that, patient looking these lines wavy or distorted.
Maculopathy. Maculopathy.
Maculopathy. Maculopathy. If it is a maculopathy, what following would be the best next step?
Immediate referral to save the
Laser
eye.
GP. Immediate referral.
Yes.
That means you are thinking age-related macular degeneration.
Yes.
Yes.
So will you say immediate? Immediate mean emergency.
Sir, it
Urgent
will be urgent.
ophthalmological referral.
Dr.
Urgent.
Arjan doesn't mean immediate. We discussed many times before. Don't be
Yes.
confused. This is an English word.
Urgent
Urgent
mean
means
within
usually
6
within
weeks.
2 weeks.
2
Within
weeks.
2 weeks.
So where to refer again? If you say urgent, ophthalmology or optometrist, say now the trap for you there.
Ophthalmology.
But again
Ophthalmology.
that you may not refer, you can do something also. Anybody having any idea, you can share your opinion.
Ophthalmology.
Sir, ophthalmologist.
Malwari checkup.
Urgent ophthalmology referral, you are meaning. Okay. I will tell something more also. Maybe this will be the picture, right, of the patient?
Yes.
Clear
Yes, sir.
now? Age-related macular degeneration. I am repeating the
Malwari checkup.
discussion because of sorry, somebody telling something, cannot understand. Anyway. So anyway, now a clinical examination by you. Again, it may be a question in the ACAT. To be confident more, one clinical examination you can do in this patient. What is this?
Shut up, you
Os-
Malwari
Amsler
Indian.
Amsler grid test.
Yes, Amsler grid. They like the Venetian blind. Amsler grid. Grid means horizontal lines and crisscross lines. They will be wavy and the distorted. It is called Amsler grid. Again, Amsler grid may be a device in your OSCE exam. So you must remember and know about. So wavy, distorted vision, macular degeneration. There will be associated one disease in the mental illness. Who can remember?
Yes.
Charles
When
Bonnet.
Charles Bonnet.
Charles
Charles
Bonnet
Bonnet.
syndrome.
Yes.
Charles Bonnet syndrome. Next question. Any new colleague wants to read for us today? Who will be? Dr. Rita?
Yes, sir.
Why you are not taking the floor? We are inviting any colleague today. Don't mind anyone. Please,
Yes,
Dr.
sir.
Rita.
What does this retinal photograph show in diabetic patient?
So you know that diabetic patient. What you are looking there? So these are the some features of the diabetic retina. What feature you are looking? Very simple questions. Please respond.
Diffusion bodies.
Already many features written there also. Options are given. So made the question simpler for you today.
It's
Question में
pre-proliferative.
pre-proliferative retinopathy.
Proliferative.
Why, doctor, pre-proliferative?
Multiple vascularity.
Vascularity. Pre-proliferation means you mean that did you identify any dot and blot
No, it's
or in
actually it's
microaneurysm?
pre-proliferative.
Yes, sir, there is
Seems like
microaneurysm.
There could be microaneurysm, right? May not be dot and blot also, but microaneurysm, you see, near the vessel is a
Yes, sir.
technical, just I'm explaining technically. If you find any dot near the vessel, it could be microaneurysm. So microaneurysm is not a normal features in the
Hey,
retina.
Malwari, are you a doctor?
Sorry, who is talking? Somebody talking a little differently. Please, if you want to talk, tell very clearly, doctor. Sorry, something happened, maybe indirectly. So this maybe is microaneurysms could be there. So we can say, can we say this is background diabetic retinopathy or pre-proliferative retinopathy? Can you remember the discussion, Dr. Rita?
Yes, sir.
Should we say pre-proliferative or background?
Sir, pre-proliferative retinopathy.
Did you shut up?
Oh, sorry.
Sir,
Who?
Sir,
somebody is in the
block
group,
this
sir.
person.
Please remove. Yes, sir. Remove that person.
Someone
No,
is.
someone maybe not as a doctor or some, sorry to say. I'm muting all now and you can open the mic. Any colleague wants to talk, open the mic. Dr. Rita, please.
Oh, it's background.
Right.
Pre-proliferative, there is little bit neovascular.
So you now compare with this picture. So what do you like to say? Background diabetic retinopathy, not the pre-proliferative means very significant dot blot hemorrhage. There will be exudate
Sir,
and
hurt
that
both,
is
के.
So
very difficult to identify anyway.
Sir, who's this Papaji? I think he's this one, Papaji.
no,
Sorry,
Dr.
better not to comment. Okay, ignore it, please. So this is the background diabetic retinopathy. Background diabetic retinopathy, as there is a microaneurysm. Okay, but don't be confused with the maculopathy. Maculopathy is not as a part of the what I say the retinopathy issue of different phases, pre-proliferative or proliferative. Maculopathy can happen in any time. So whenever you see that the microaneurysm, we can say this is background retinopathy, and is very characteristic. Okay.
Okay.
Somebody say it is a dot hemorrhage, but it is actually, try to remember the dot hemorrhage, blood hemorrhage and microaneurysm. Try to understand three things separately. It will be easy to understand. This is a background retinopathy. Now this picture. Who, doctor, to read again? Doctor, any other new colleague? Feel free to read. Dr. Nawaz, please, you can.
Yes, sir. Which of the following drugs may be responsible for this appearance?
Yes, this is the appearance. Which drug is a technical question. Already you identified the diagnosis of the retina. What is the diagnosis? The retinal diagnosis? By looking.
It's
a hemorrhage, sir.
retinoic acid.
Hemorrhage. No, not hemorrhage. First look at the disc, doctor.
Sir, it's
Papillary
optic.
edema.
Papillary
Yes.
edema. Now the remaining retina is okay or not?
Okay.
Okay.
Retina is okay.
So could you think that this is hypertensive retina?
No, it's due to drug induced.
No. I'm asking, is it hypertensive or not?
No.
No, because if papillary edema is there, there will be some other grade 1, 2, 3 features of hypertension as well.
So it's due to combined oral contraceptive pills.
What will be the underlying retinal diagnosis?
It's papilloedema
Could be due to
because
idiopathic
central origin of
idiopathic
the
intracranial hypertension,
yes,
idiopathic
idiopathic.
intracranial or benign intracranial hypertension.
Yes.
First of all, you diagnose it. Now, see the relationship with the predisposition or etiology. It is actually not etiology. It will be risk factor for to develop. So, what could be important cause? Most
COC.
COC. So you're blaming COC and not to give COC to the patient.
May
Combine.
cause, yes, they may cause intracranial,
Could it
benign
be
intracranial
tetracycline? Could it be tetracycline? Dr. Shazia,
topic.
what you were thinking? Could it be tetracycline?
Sir, it's topical. Topical, how can topical cause idiopathic intracranial?
Okay, now try to learn about the patient now. Yes, Dr. Nawaz.
Yes, 32-year-old female is referred with a 6 months history of headache. She is taking medication for acne and contraception. Examination reveals his fundal appearance, a BMI of 33, a pulse of 75 beats per minute, regular, a blood pressure of 120 over 74, and a temperature of 36.7.
Fundoscopy shown. So
Which
we
of the
already
following
discussed,
best?
and this is the background of idiopathic intracranial hypertension, obesity, female, OCP, not OCP, but patient is taking the treatment for the acne, right? OCP
Yes.
already on the contraception. So acne treatment include the tetracycline, retinoic acid, right? So many risk factors are there. Many risk factors are there. And one thing also we are learning, only not for the fundoscopy, that we are treating the patient for the acne and patient may develop headache later. What should we suspect?
If he or she taking oral retinoids, then it may cause intracranial pressure
Not only
increase.
retinoic, doctor, even the tetracycline orally also, it can
Okay,
cause headache.
oral. Okay, oral.
So that means we are treating acne and creating the problem of intracranial hypertension, right? Iatrogenic. Is it? Iatrogenic. Anyway.
Yes.
So now cause will be, you are telling this is combined contraceptive pill. Yes, this is the answer. So this is a puzzling that topical or systemic. Now I think
Very
you're
nice.
clear.
Very nice.
Very good. So I think we should proceed further. If you feel interest, should we continue, Dr. Nawaz?
Yes, yes, sir. Yes, sir.
Otherwise, actually, my primary intention up to these for the beginners. If anybody tell that it may be complicated and further, I like to stop here also.
No, no, sir. Carry on.
No,
After,
sir, please continue.
yes,
Right.
after days we found your voice and it's lovely session.
Thank you, doctor. No problem. But in the Ramadan first day, with any having any trouble with you or not? Let's see. And you look at the retina. A lot of vessels you can see, right?
Yes, sir. Vascularity.
Why?
S-
Sir, can I talk please? Am I audible?
Diabetes,
Yeah, I
diabetic
can hear
patient.
you, Dr. Namra.
Sir, I joined late. Can I get the recording from the
Sorry,
start of
doctor,
the...
tell it later, not now, in the middle.
Okay.
You can communicate with us later. Let the session be finished.
Yes, sir.
Dr. Namra, are you a candidate for AKT or OSCE?
Yeah, sir, I'm candidate for AKT.
Oh, fine. Yes. OSCE also important today's class because OSCE will not extend more these pictures I know about. Okay. So today's session important for the OSCE as well. So in the retina, you see that there is no pigment. Okay. And it
Yes.
happened from the birth. What could it be? And this you see the optic disc, the vessels are coming from there. So you are looking too much vessels. Reason is that there is a no blackening. As in the normal
Yes.
retina, there is a blackening pigment layer of the retina, you know. You can remember one layer of the retina is the pigment layer. So as the pigment layer is there, you are not looking too much vessels, capillaries and arterioles. Very significant, few 8 or 10 vessels are there. But here, all the vessels are visible. It is not the excessive vessels, but technically vessels are visible due to the background is white. No pigment is there. What is the condition now? From the birth it happened. Can anybody comment? Dr. Vitiligo happen very little here and there. And this patient whole body also will be white if it is. But ocular albinism is a separate word. It is albinism. Albinism. So it is albino fundus. Okay. It is called albino fundus. And usually if light focuses on the retina, retina will be irritated. Pigment layer is protective. If pigment layer is not there, the retina will be irritated. So what patient eyes will do? Patient eyes will be in continuous nystagmus. Okay, continuous moving eyeball. So this is albino fundus. Okay, albino fundus. Now look at this picture. Who can comment here? Look at the disc, look at the vessels, and look at the retina. And there is something.
Strawberry mark,
Retinal vein occlusion.
A strawberry appearance. A strawberry
retinal
appearance.
artery. Yes, strawberry appearance and retinal artery occlusion.
Retinal artery occlusion. What is the evidence that artery occluded?
Because it's paler, having a
Paler.
strawberry
Oh. So
retina
we have
is
to be very confident, and what I say, the in a comparative mind, that the background of the retina color is white, black, or others. Otherwise, you
Very
cannot identify. It could be white or more also. It could be milky retina. Okay, milky retina, white, too much white also, more than this white also. If it is that white, as the central retinal artery is there and it is divided here to give the branches, as some vessels may not be visible, and the cherry red spot, that is the macula. Actually the macular vessels is there have some separate arterial supply, not from there. For this reason, the blood supply to the macula may not be hampered too much, and in the retina this area will be clearly visible. Usually it is called cherry red spot. So this is central retinal artery occlusion. Central retinal artery occlusion. Okay, there are some other extra features. Anybody feel free to make a snapshot, not to describe much here. There are other features as well. For the advanced level, actually, I am very shaggy to say very advanced topic today. Now that this one, what you are getting?
So it's what, retinal detachment or what?
No, not retinal detachment. You are looking the vessels here.
Yes.
Okay, but the some area of the retina is white. White means ischemia, but the whole retina is not white.
A branch of retinal artery.
Very easy to say in this way. Is there also cherry red spot? Yes, you see cherry red spot in this area. So this is the branch retinal artery. As you understood the central retinal artery problem, so now the branch retinal artery, that means whole central retinal artery is not in trouble. So this is the branch retinal artery. So you are looking now that there may be ischemia, later on something happened, but initially it could be like this, branch retinal artery occlusion. It is called simply brow. Okay. What is this? Whole retina is the stormy red.
central vein occlusion.
Central vein occlusion.
So now, so you are telling that the retina become having more blood in the venous occlusion rather than arterial occlusion, is it?
Yes, occlusion.
It is true, because blood is going back to the heart from the retina, but it cannot go. So blood is congested in the retina and there is hemorrhage. So this is central retinal vein occlusion. Central retina means whole retina is in trouble. The name of the appearance sometimes told as stormy sunset. Sunset. Stormy sunset. There might be features of hypertension also as well, remember, because the central retinal artery occlusion or central retinal vein occlusion, even the branch also, patient might have diabetes, hypertension, dyslipidemia, all cardiovascular problem as well. So this central retinal vein occlusion, central retinal vein occlusion. Now this one, is a
Branch
vein
vein,
occlusion or arterial occlusion?
branch vein occlusion,
Vein occlusion. Why not arterial occlusion?
because congested area is congested, not paler.
Yes. Rather to say not congested, directly we can say hemorrhage. Okay, hemorrhage, congested with hemorrhage. So this is venous problem. Arterial problem will be whiter. So you now understand that these fundoscopic pictures are not very critical and complicated. Actually, I told you initially that sometimes we are ignoring it. That okay, it may be very difficult to learn. Okay, ignore it. Other than I will not be ophthalmologist or other like this. But I believe that today's discussion will make you to give an impression that these fundoscopic pictures are easy.
Yes,
Those
sir.
who are attentive today, you will understand. Those who couldn't attend me, sorry to say, again, it will be difficult for you. So this is branch retinal vein occlusion. So where is the hemorrhage? It will be the venous occlusion. Okay. Now this one. What you are thinking happened there?
Photocoagulation.
Yes,
Photocoagulation.
post-operative.
Photocoagulation. Now asking you about additional question. If it is a photocoagulation, okay, let me say that this is a photocoagulation. Diabetic proliferative retinopathy, many things are there. I am asking another question. I hope all of you can give the answer. Then I will think that today's discussion will be a successful one. In the central part, optic disc is normal or not?
No.
Oh no.
Cup disc ratio is increased.
Yes.
There is no disc, doctor. You see again the vessels coming from the center.
Yeah.
So it is not glaucoma.
No.
So what is this condition of the optic disc?
Papillary edema.
Not at all.
Not at all.
Looks atrophic.
Atrophic, right. Atrophic. Now what is the type of atrophy? There are three types.
Primary, second.
Primary, secondary, consecutive.
Consecutive. Sir, consecutive.
Photocoagulation.
Consecutive. Why not
Consecutive.
secondary?
So this is due to retinal problem.
Yes, doctor. This is very due to retinal damage associated optic disc problem. Why not this is primary? Because
retina is
Well, it's
also
not
there.
retina
involved
is
at
in
this point.
trouble.
Damage.
The primary optic means only optic disc is in trouble. Otherwise, fundus is normal. Okay? Very
sir.
good, doctor. Thank you very much as you got the points today's discussion. And now your time, doctor, for interaction. Better not to proceed further. Whatever you have gained today, you just culture and nurture in your brain, in your discussion, and try to utilize in your practice. Any queries, doctor? Until now, we discussed about. No more. Usually, nobody asks the question. Everybody listener. Okay. And for the further discussion, somebody also requested for the link and other. Already one link is available in the YouTube. Okay, you can send a request in the WhatsApp group, doctor. So thank you everyone to be with us. Have a nice day.
Thank you
See
so
you
much.
again.
Thank you
To
so
see you
much.
again.